Hello and welcome to the topic Hyper and Hypocalcemia in the Endocrinology module. By the end of this session, you should be able to define hyper and hypocalcemia, explain the pathophysiology and causes of hyper and hypocalcemia, describe the clinical manifestations of hyper and hypocalcemia, outline the investigations to ascertain the causes, and discuss the approach to endocrine-related hyper and hypocalcemia. Let's get started. So we will begin with hypercalcemia. Hypercalcemia is defined as raised total serum calcium levels, which is more than 2.62 millimoles per liter. Hypercalcemia is further classified as true hypercalcemia and factitious hypercalcemia, where true hypercalcemia is the raised free calcium or corrected calcium regardless the total calcium levels. And factitious hypercalcemia is high total calcium with normal free calcium or corrected calcium. In general, causes that contribute to the progression of hypercalcemia can be grouped as parathyroid hormone-mediated or non-mediated. In parathyroid hormone-mediated, primary, secondary hyperparathyroidism, and where primary is one of the major factors contributing to the progression of hypercalcemia. Next, familial hypocalciuric hypercalcemia is also mediated by parathyroid hormones. Meanwhile, non-parathyroid hormone-mediated causes are malignancy, medications, and thyrotoxicosis, adrenal insufficiency, granulomatous disorder, and prolonged immobilization. With one or more of these causes contributing, one develops a state of hypercalcemia. The pathophysiology will be discussed soon. So here, the pathophysiology of hypercalcemia arises from various etiologies which causes increased bone resorption, intestinal absorption, renal reabsorption, or reduced renal excretion leading to hypercalcemia. Its effects on renal, muscle, and CNS and bone can be discussed distinctively. In the cardiovascular system, hypercalcemia increases myocardial contractility and irritability, which can be notifiable in ECG. Next, as calcium is an essential electrolyte in the nervous system, hypercalcemia decreases neuromuscular excitability, leading to hypotonicity in muscles and diminished deep tendon reflexes. Following diminished smooth muscle excitability, gastrointestinal activities reduces, resulting in constipation, increased gastric residual volume causing nausea and vomiting. Besides, high calcium increases delivery of calcium to the nephron, resulting in nephrogenic diabetes insipidus, causing impaired vasopressin binding with aquaporin downregulation and renal interstitial sodium concentration, which leads to reduced urine concentrating ability, resulting in intravascular volume contraction and subsequent reduction in glomerular filtration rate. Lastly, osteolytic metastases or humorally mediated bone resorption are due to hypercalcemia of malignancy, which causes secondary fractures, skeletal deformities with bony pain. In general, patients may find symptoms suggestive of hypercalcemia as asymptomatic. In contrary, some cases might be incidental findings through lab investigations. The mnemonic stones, bones, abdominal moans, and psychic groans describe the constellation of symptoms and signs of hypercalcemia. Clinical manifestations of hypercalcemia can be discussed according to systems involved, like, for example, for the urinary symptoms, it would be changes in urinary output, voiding symptoms due to renal stones. Next, for GI symptoms, these are constipation, nausea and vomiting, loss of appetite, and abdominal pain. And some patients may present with cardiovascular symptoms like chest pain, palpitation, syncopal attack, hypotension, and arrhythmias. Symptoms suggestive of nervous system include drowsiness, confusion and headaches, somnolence, reduced tone and reflexes. And in regards with musculoskeletal system, patients complain of bony pain, muscle pain or tenderness, and signs of fracture. With history and physical exams suggesting that this could be a case of hypercalcemia, lab tests should be done. In practice, we would first confirm true hypercalcemia by first obtaining measured ionized calcium or calculated corrected calcium by using the formula measured total calcium plus 0.8 multiplied by 4 minus serum albumin. Once hypercalcemia has been confirmed, further lab studies are needed to be done to identify and manage the etiologies. Tests that can be obtained are serum parathyroid hormone levels, vitamin D levels, serum cortisol level to assess adrenal insufficiency, CT abdomen and pelvis to assess for tumors, skeletal survey to assess lytic bone lesion, bone densitometry to evaluate of patients with primary hyperparathyroidism. Lastly, few tests are done to evaluate the complications such as electrocardiography to assess arrhythmias, and these ECG findings are typically ST segment elevation, biphasic T waves, prominent U waves, and shortened QT intervals. Renal function tests also can be done to calculate the glomerular filtration rate. Now, let's take a look at the management. Principles of management of hypercalcemia are adequate resuscitation in severe dehydration, providing adequate supportive care, and identify and treat the underlying cause. First-line management plan that is commonly practiced are resuscitation, where patients with physical examination suggestive of dehydration need to be adequately resuscitated with normal saline and reassessed for circulatory return. Loop diuretics, once circulation has been restored. Administration of loop diuretics block sodium and calcium reabsorption. So you identify and treat the etiologies such as surgery, calcimimetics, and corticosteroids. Treat the complications like arrhythmias and nephrolithiasis. Consider hemodialysis for refractory life-threatening hypercalcemia, and supportive care such as ensure adequate hydration, reduce dietary calcium intake, avoid drugs which exacerbate hypercalcemia like thiazides, lithium, vitamin D, calcidiol, and calcitriol, and encourage mobility and avoid prolonged bed rest or inactivity as immobilization increases serum calcium. Upon first-line care, pharmacotherapy is given as it inhibits bone resorption. Choices include calcitonin with rapid onset with short-term control on calcium level and reduces calcium level within 2 to 6 hours, and bisphosphonates with slow onset, long-term control of hypercalcemia, example zoledronate or pamidronate. It normalizes serum calcium within 2 to 4 days with effects sustaining up to a week after administration and contraindicated in severe CKD. Surgery is the last option in line with management plan of hypercalcemia. It is considered to correct the etiology, especially hyperparathyroidism or hypercalcemia of malignancy. Examples of surgery are partial or total parathyroidectomy and resection of the tumor. With history and physical exam highly suggestive of hypercalcemia, it's essential to confirm if it is true hypercalcemia. Next, parathyroid hormone level is measured to rule out parathyroid gland involvement in hypercalcemia. Once parathyroid hormone is suppressed, further workup needed to be done to identify if the etiology is either hypercalcemia of malignancy by testing alkaline phosphatase level, parathyroid hormone-related protein, and in cases workup for malignancy is negative, evaluation for endocrinopathies are done. Lab tests for endocrinopathies are free thyroid hormone to evaluate for hyperthyroidism, serum cortisol for adrenal insufficiency, and insulin-like growth factor for acromegaly. Now, we're done with hypercalcemia. Let's move on to hypocalcemia. Hypocalcemia, on the other hand, is defined as total serum calcium concentration less than 2.2 millimoles per liter in the presence of normal plasma protein concentrations, or as serum ionized calcium concentration is less than 1.17 millimoles per liter. In contrary, factitious hypocalcemia is asymptomatic decrease in total calcium levels with a normal ionized calcium level occurring typically due to low serum protein levels. The causes of hypocalcemia can be grouped as electrolyte imbalance, and this can be due to hypoalbuminemia, hypomagnesemia, hyperphosphatemia, and other factors such as multifactorial enhanced protein binding and anion chelation, medication effects, surgical effects, parathyroid hormone deficiency or resistance, vitamin D deficiency or resistance. The pathophysiology of hypocalcemia arises from various etiologies as mentioned. Its pathophysiology can be discussed according to involved system, with nervous and cardiovascular system being the commonly involved. In cardiovascular system, hypocalcemia impact cardiac contractility because of the sarcoplasmic reticulum is unable to maintain sufficient amount of calcium content to initiate myocardial contraction, presenting as congestive heart failure, hypertension, and cardiac arrhythmias. Next, as calcium is an essential electrolyte in the nervous system, hypercalcemia increases neuromuscular excitability leading to paraesthesia, muscle spasm, stiffness, myalgia, tetany, Fox-Tek sign, and Trousseau sign. Calcium in the epidermis are essential in regulating many skin functions, including keratinocyte differentiation, skin barrier formation, and permeability barrier homeostasis. In line with that, chronic hypocalcemia may have dermatology manifestations like coarse hair, brittle nails, psoriasis, and dry skin. Clinically evident hypocalcemia generally presents in milder forms and is usually the result of a chronic disease state. Acute manifestations of hypocalcemia are angina, syncopal attack, acute heart failure signs like pulmonary edema and hypotension. Systemic manifestations are grouped according to involved system. For example, in the nervous system, patients may present with numbness and tingling, muscle cramps, irritability, seizures, and positive Chvosek sign and Trozo sign. In the cardiovascular system, the clinical manifestations are like bradycardia or tachycardia, S3 heart sounds, and signs of heart failure may be present. In the respiratory system, signs that can be appreciated are inspiratory or expiratory wheezes, which may be present, and smooth muscle contraction, which may lead to laryngeal stridor, dysphagia, and bronchospasm. In few cases, dermatological manifestations are appreciated like coarse hair, brittle nail, psoriasis, and dry skin. With history and physical exams suggesting that this could be a case of hypocalcemia, lab tests should be done. In practice, we would first confirm hypocalcemia by obtaining measured ionized calcium or calculate corrected calcium by using the formula measured total calcium in milligrams per deciliter plus the multiplication of 0.8 and 4 minus serum albumin in grams per deciliter. So the liver function test to evaluate serum albumin level is also another test that helps us confirm hypocalcemia. Once hypocalcemia has been confirmed, further lab studies needed to be done to identify and manage the etiologies. Tests that can be obtained are serum parathyroid hormone level, serum magnesium and phosphate level, serum cortisol level to assess adrenal insufficiency, alkaline phosphatase, and a 24-hour urinary calcium level. Lastly, few tests that are done to evaluate the complications such as electrocardiography, which is to assess arrhythmias, and the kind of ECG findings that you would see would be ST segment prolongation and prolonged QT interval, and venous blood gas alkalosis, which may worsen tetany. The mainstay therapy of hypocalcemia consists of calcium supplementation and the treatment of underlying cause. Calcium supplementation can be provided according to the severity of hypocalcemia, where in cases like severe and or symptomatic hypocalcemia with presence of tetany, seizures, prolonged QT interval, and serum calcium of less than 1.9 millimoles per liter, you may provide the patient with intravenous calcium supplement, either calcium gluconate or calcium chloride, and consider transfer to the critical care unit. As for mild or chronic hypocalcemia, which they are asymptomatic or only mild neuromuscular irritability and has serum calcium levels of 1.9 to 2.12 millimoles per liter, provide oral calcium supplementation such as calcium citrate, calcium carbonate, and that will be adequate. Then, once supplement is given, identify and treat the underlying cause to prevent recurrence. Treatments are planned according to the etiology identified during investigations such as hypoparathyroidism. And for example, the kind of treatment that you can give would be calcium supplement plus vitamin D supplementation. And if secondary to loop diuretics, consider to discontinue loop diuretics and change medications to thiazide. In vitamin D deficiency, you should provide vitamin D supplementation. Hypomagnesemia-induced hypocalcemia, you should provide magnesium supplementation. And hyperphosphatemia and chronic kidney disease can be also treated with phosphate binders, such as also with calcium supplementation, for example, calcium carbonate. With history and physical examination highly suggestive of hypocalcemia, it is essential to confirm if it is true hypocalcemia by measuring serum albumin levels. On the other hand, with normal serum albumin level, it is essential to measure urinary calcium level to identify the etiology. With high urinary calcium level, hypercalciuric hypocalcemia can be diagnosed. Then, by evaluating the phosphate level, hypoparathyroidism and vitamin D deficiency can be ruled out as well. We have come to the end of this topic. Thank you.